But although the patient is spending a little less time in the clinic, the administration actually requires the nurse to be at the chairside the entire time. This has allowed nurses to spend potentially uninterrupted time to sit and converse with the patients that they may not have had with an IV infusion. It's been wonderful, unintentional outcome from the development of the large volume sub-Q injections.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Crystal Derosier, Clinical Specialist at Dana-Farber Cancer Institute in Boston, Massachusetts, about administering high-volume subcutaneous injections in oncology. This episode is part of a series about oncology nurses' role in administering cancer treatments. We've linked the others in the episode notes. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Welcome, and thanks so much for joining us today, Crystal.
Yes, thank you so much for having me today, Jaime.
So subcutaneous injections, sub-Q injections, we use them in many different healthcare disciplines and settings. But can you give us a brief overview of how they are used in oncology?
Subcutaneous injections are, as we know, are very prevalent in oncology care and can often be seen as part of the patient's treatment plan or their supportive care plan. One would think an injection is simple, but these injections are often complex in terms of administration considerations or even patient considerations. Subcutaneous injections can be seen in oncology setting as supportive treatments such as B12 or growth factor supports, but also as an anti-cancer therapy such as Velcade, rituximab, daratumumab, teclistamab, and talquetamab. This is not an exhaustive list, though, as there are many, many more supportive therapies out there and anti-cancer treatments that are currently available in the subcutaneous form.
So how has this use and this route of administration, how has it changed over time?
As we know, oncology in general is a rapidly evolving field, especially as new therapies are continuously and constantly being FDA approved, which is great for our patients. It's a lot for the nurses to learn as well. For many years, the standard of care for anti-cancer agents were IV therapies, intravenous preparations, or administrations. But we're starting to see that these existing therapies, IV anti-cancer agents, are becoming available and improved in a subcutaneous formulation. In addition, also new novel agents, as I had mentioned before, our bispecific therapies are becoming available right from the start as sub-Q injections. So the sub-Q climate is really hot right now.
You're absolutely right. And while it does seem like a minor, simple change from one administration route to another, I think we are all acknowledging that it really kind of turns our work on its head a little bit in terms of not only the throughput and how patients experience their visit with us, but sort of how we have to monitor them and just sort of prepare ourselves for giving them that treatment as well. So let's talk about that a little bit more. What are some of the advantages of using sub-Q administration compared to other routes?
We know that there are many advantages to using the sub-Q form of a drug. We know that this route can help with optimization of our healthcare resources, can help reduce patient chair time, hospitalizations, making administrations more cost-effective for not only the clinics, but also insurance companies as well. We also know it's very advantageous for the patients as they're able to spend less time in clinic receiving treatment, and they're able to go out and do the things that they want to do instead of spending time receiving treatment for long duration infusions, observation periods, all of those things. So there are a lot of advantages for using the sub-Q route.
I really like that. And I appreciate you mentioning that the sort of concept of time toxicity is, I think, gaining traction of just recognizing how disruptive it can be for patients and their family and caregivers to find the time to come and spend that long, lengthy day with us for treatment, depending on kind of what their treatment regimen is. And so that is certainly one advantage that I think is very beneficial to patients. And hopefully that they are seeing the benefits of that.
Absolutely. And, that's a good point too, when we're thinking about their family as well. Maybe they're getting to spend time with family in the clinic, but better served to be doing that outside of our healthcare setting and spending more time with them there.
So what are some of the limitations for sub-Q injections?
With everything in healthcare, there's always some limitations. Some challenges with subcutaneous injections are with the administration, especially when we're thinking about large volume drugs that we'll talk about in this podcast. Some of these patients who have been through multiple therapies, they've been on a long journey, or just in general, they may have small amounts of subcutaneous injection areas and tissues. So that could be problematic. We also see that sometimes insurance coverages may also influence the preferred product for administration. This is rare, but it can happen. Also, some patients may want to go back to receiving IV medications if they experienced severe pain at an injection site during administration, or maybe they had a site-related reaction. This is where the nurses play a huge, crucial role in the administration of these subcutaneous drugs.
Thank you for that. And the point about insurance coverage is, it just sort of makes me smile a little bit. It's like anytime something new comes along, it sometimes takes them a while to get on board. So it's unfortunate if that's becoming a barrier in these early days as these drugs are either, as you mentioned, either coming out with approval as a sub-Q method of administration, or if this is something that previously was an IV version and now this is a new opportunity. So hopefully those barriers will be eliminated fairly quickly so that this can be an option for all patients.
And I'll talk about it a little bit later too, but some of the barriers are the perception from the patients or maybe the providers. They're not well versed in these drugs yet, thinking it might not work as well. If I'm here for a short period of time, it can't work as well as like the IV form. So we'll talk a little bit more about that too.
We as nurses are quite familiar with your average, relatively small sized sub-Q injection in various settings and sort of all specialties. But what are some of the indications that we're seeing for these larger volume sub-Q injections? And what types of drugs or treatments are we routinely seeing administered via this route in the oncology setting?
As I mentioned before, this is not an exhaustive list, but I will mention a few. As we know, large volume injections are defined as 5 mLs or greater. Right now, we have a lot of monoclonal antibodies that are available in the subcutaneous route. These include rituximab, daratumumab, trastuzumab, pertuzumab, and trastuzumab, also known as Phesgo, all with hyaluronidase, and they range from volumes of 5 to 15 mLs. Nivolumab and atezolizumab are the most recent sub-Q formulations that have been approved by the FDA. Rituximab is indicated in the setting of follicular lymphoma, diffuse large B-cell lymphoma, and chronic lymphocytic leukemia, CLL. Daratumumab is indicated in many multiple myeloma settings. Trastuzumab and Phesgo in the setting of HER2-positive breast cancer. I should say we should also always refer to the manufacturer labeling for more specifics on indications and usages, as they are always approving for new indications, what feels like weekly, which is great.
And what an interesting time to be practicing in oncology of it's not just what is the next drug that is approved in your average IV administration, but now it's maybe a drug that I am familiar with, but the approval is to switch the route in which we give it. And so again, making sure that we, as you mentioned, great advice to always be referring to the most up-to-date, the most recently approved package insert to make sure that it's reflecting all of these later approvals that may impact the instructions and the route of administration.
And that's a great point. I remember when daratumumab was approved in the sub-Q formulation, and that was revolutionary. The patients were in the chairs for so long. There were high rates of reactions. We had to pre-medicate them and medicate them during the infusion. It was a lot. It was burdensome for the patients, their families, the caretakers, the nurses, providers. So that's just one example of how great sub-Q options have been for the oncology care.
So let's talk about supplies and equipment. What are the equipment and the supplies needed that nurses should be prepared to gather as they are with their patient getting ready to give this type of injection?
For all injections, the appropriate personal protective equipment, PPE, should be worn, especially for any hazardous drug administration. The nurse should also gather supplies such as alcohol, pads, and gauze. And unless otherwise specified by the manufacturer, for small volume drugs, it's recommended that a 1 to 3 ml syringe is needed, alongside a 25 gauge to a 30 gauge needle with a length of 1/2 inch to 5/8 inches. For large volume injections using a traditional needle, a syringe based on the drug volume is needed. You would use a 25 gauge to a 30 gauge needle that's 1/2 inch to 5/8 inch in length. For large volume subcu injections, you can also use a winged set. This technique would require a syringe based on drug volume as well as the winged set. And we'll talk a little bit more about those wing sets coming up.
Wonderful. So yeah, I think that this is part of, as we started off, the subcu injection on its face seems pretty simple, pretty straightforward. But as we get into these larger volumes, we've had to consider our practice in terms of how we administer these injections and sort of things to consider as we take on this relatively new procedure. So what are some of the best practices for administering these larger volumes? And are there any special precautions that nurses should take when administering the large subcutaneous injections?
Like you said, when these drugs first came out, we were doing a traditional needle for everyone. That's all we knew with our standard subcutaneous injection practices. But we really needed to assess our practices. Nurses were uncomfortable, patients were uncomfortable, and they weren't really tolerating the drug as much as we'd want them to in terms of injection site comfort. So we know that positioning is crucial. Nurses should ensure that they're in a comfortable position prior to and during the administration. As I said, they often voice experiences of fatigue and discomfort when administering large volume subcutaneous injections. Good ergonomics is very important during the administration because this can help reduce the fatigue and discomfort, not only for them, but for the patients as well. If you're trying to hold the needle in place for 5 to 10 minutes, it's a lot of work. Your arms can start to shake, and that shaking can cause discomfort for the patient as well. The utilization of a winged infusion set for these large volumes allow more space between the patient and the nurse, which supports better ergonomics. There are other factors, though, to consider for these injections to make the patient more comfortable through different drug administration techniques. We know that we should have the bevel of the needle inserted up, as this can reduce pain at the injection site, as well as the utilization of the air sandwich technique. The rate of administration can also impact patients' pain. The large volume injections have very specific durations that are outlined by the manufacturers that nurses are to inject this drug over. The duration should be followed, as going too fast can increase injection site pain, and it can also be challenging for a nurse to hold the needle, as I said, at the injection site for extended duration, which is why a winged infusion set for large volume injections can help inject at a consistent ordered rate.
Thank you for describing that. Again, I think this is a technique that many nurses at their sites of care are experiencing maybe for the first time, as it has become more predominant for these therapies that are given in community settings. So can you maybe walk us through just some quick how-tos of how a nurse should consider and be prepared to walk through this process?
I would always defer to one's institutional policies and procedures for any specific administration instructions, as well as the package labeling. But as we see more of these large volume subcutaneous drugs hitting the market, the drug-specific educational materials are actually inclusive of using the 23 to 25 gauge infusion sets. And I'm going to review this administration using this method as well as a traditional needle. Again, for nurse autonomy, if you do feel more comfortable using a needle, that's great. You can also use the winged method as well. So you'd want to select the appropriate administration site of the drug to be administered. As always, performing hand hygiene and donning the appropriate PPE. You'd cleanse the site, let it dry. And whether you're using a traditional needle or a winged infusion set, ensure the bevel side of the needle is up, as this can help reduce pain at the injection site. If you were to use a winged set, you'd pinch the wings together and then pinch the skin at the designated injection site and insert the full length of the needle to the hub at a 45-degree angle. There should not be blood return, and inserting up to the hub ensures the catheter will remain at the designated angle. Prior to drug attachment to the winged set or a traditional needle, one could use an air bubble technique to ensure that the drug's clear from the catheter in the syringe upon completion, and also to reduce site reactions. You would attach the drug syringe to a winged infusion set or a traditional needle and administer over the ordered duration. And then upon completion, you're removing the infusion set or the traditional needle from the site, engaging any safety mechanisms, and placing in the appropriate waste container.
Thank you for that walkthrough. It certainly is helpful to kind of help visualize those steps. And as you mentioned, it's important to review your institution's policy and procedure that guides this. And you might discover that maybe it needs to be updated to be inclusive of these larger volumes and these optional methods using either the winged infusion set or your standard needle, making sure that your policy supports both of those options for practice.
Absolutely.
So let's talk a little bit about selecting that injection site. What are the body areas most appropriate to use? And are there certain characteristics of a good injection site that nurses should be looking for?
Injection sites are really dependent upon the drug that it's administered. The areas often injected are thigh and abdomen, but it is always important to check the drug prescribing information to ensure the appropriate site selection is made. We do know that patients will often say, can you inject here? What about here? I don't like it here. So it is important to remind them and review the package labeling of why you're choosing that site. Once the site is selected, it's important to assess the area and avoid injecting into any tattoos, scars, or areas where the skin is red, bruised, tender, hard, or not intact.
So naturally, with a larger volume, that we aren't surprised to maybe know that patients can experience pain or discomfort while they're receiving that large volume subcu injection. What are some interventions that nurses can use to help reduce their pain or promote their comfort during their subcu injection?
I think we did talk a lot about the different techniques of the bevel, the winged set, the air sandwich. In addition to that, when we think of pain at an injection site, we would want to grab a hot pack, a cold pack, put it on the site, right? As nurses, we don't want to cause any pain or harm to our patients, but unless otherwise stated by the drug labeling, it is crucial that we avoid this practice to prevent any altered absorption or dispersion of the injected drug. Instead, focus on the proper techniques and the ergonomics that we talked about.
I think it's important that you brought it up earlier. It's obviously our focus and remains on the patient and the pain that they're experiencing and trying to mitigate or avoid that or help to address that as much as we can. But it's important for nurses to be considerate of their own pain. And if they are hunched over, if they're crouched down in some sort of uncomfortable position, that if it was just a quick 5-10 second thing, maybe they could just deal with. But as you mentioned, some of these injections are done over minutes, 10 to 15 minutes, sometimes even. And so really important that nurses also have awareness of their own comfort so that they're not creating risk for injury for themselves if they do this repeatedly throughout the day.
Yes. And as we mentioned, right, there's more and more of these drugs coming to the market. So more risk for doing these repeated actions over and over again, as opposed to just one here and there. So that is very important.
So let's talk a little bit about education for our patients. What should nurses be teaching patients who are receiving these high volume subcu injections?
Education is such a huge part of the nurse's role. Just a few things to be mindful of. We want to make sure that patients know to wear appropriate clothing to their appointments. We want to be able to access those administration sites for extended durations. We also want to share the duration of the injection administration with the patient and family members so they are aware of that. And as I mentioned, patients may request a specific location of administration than what is actually required. So nursing should be able to provide the rationale for the injection site choice. And it is crucial to educate the patients, of course, when to call the clinic with any issues, if they're having any redness or swelling, pus, fevers, pain, excessive bruising, bleeding that does not stop with pressure, as we need to assess what's going on at that injection site.
Absolutely. And I think you mentioned it earlier, but there is a component of perhaps overcoming patient fears and assumptions. And it's like it comes in multiple forms. I mean, I think most patients at some point in their life have received a subcu injection. I mean, even vaccines are sometimes given in that route, other injections that they've likely received over their lifetime. And so to come at them with a very large volume and tell them we're going to be giving it that way probably causes some fear for those patients. And then there's the patients who maybe have already been receiving the drug in the intravenous form. And so now we're telling them we're going to switch to this new form, this new route of administration. And so some of the questions or reasonable concerns that come with that. And so some of the things that you've mentioned here, again, focusing on what your patient's concerns are and trying to address them so that they feel comfortable and confident moving forward with this new route of administration.
Definitely. And as you mentioned, they may be familiar with getting a different type of subcutaneous injection. Maybe it's a smaller volume. So when you bring that large volume syringe to the chairside, it can be overwhelming. Where are you putting that? Is that going to hurt? So it's managing their fears as well and really educating them that it's going to be okay.
Absolutely. And, explaining and sharing how the hyaluronidase kind of functions as part of this larger volume and how that facilitates that distribution. And so again, I think just for certain patients, knowing more helps them to feel prepared and feel calm. And then there are others that are just do what you have to do. Let me know when it's over. So always trying to customize and personalize that education for our patients is really important.
Absolutely. That's a good point. You're not going to have this large volume of baseball underneath your skin until you come into clinic next, the utilization of the hyaluronidase and the mechanism of action for that too.
Crystal, thank you so much for coming in and talking about this. I think this really interesting, really exciting change and development in our administration of certain cancer treatments. I think this is something that we're excited to see as nurses, and hopefully patients who have lived through those day-long infusions are seeing maybe some of the benefits of being able to really significantly cut down on that time toxicity for them in their time spent in the treatment room. As we approach the end of our episode today, we do like to always run through a series of quick fire questions just to help summarize some of the important points that we've touched on today. And so to start that out, how do you think healthcare professionals can evaluate their hidden or their implicit bias about administering high-volume sub-Q injections?
Change management is hard. It can be challenging. As mentioned, when large volume sub-Q medications came to the market, there was a lot of pause and dissatisfaction around the new medication from both patients, families, providers, nurses, etc. A lot of the frustration was due to nurse fatigue related to the poor ergonomics, as well as perceived patient comfort. Nurses don't want to hurt their patients. It's quite the opposite. Changing nursing practice to administer these large volumes required hands-on support to change the practice from traditional sub-Q injection practice. To mitigate some of the nursing concern between traditional needles and winged infusion sets, we let them make a decision. That's our practice now. Bias was seen just to keep the practice as it always has been. But with the appropriate planning and communication and education, the ability to change the nursing preference and bias positively towards large volume subcutaneous injection has been overly favorable thus far.
What are some common misconceptions about high volume sub-Q injections?
When they came to the market, there was an unfounded concern from patients and practitioners that these injections would not be as effective as their IV counterparts. This is totally incorrect. We know that these options have the same efficacy and may actually also help to reduce the incidence of any infusion-related reactions, as well as lower side effect impacts on patients. So overall, a lot of improvement with these high-volume sub-Q injections for the patient experience.
What's something about this topic that's not often discussed, but you wish people knew more about?
We didn't really talk about this, but although the patient is spending a little less time in the clinic, the administration actually requires the nurse to be at the chairside the entire time. This has allowed nurses to spend potentially uninterrupted time to sit and converse with the patients that they may not have had with an IV infusion. It's been wonderful, unintentional outcome from the development of the large volume sub-Q injections.
And isn't that so interesting of like when they're here all day with us in the infusion center and we get seemingly few minutes to sit and just be with them, but they're here with us for hours. And now we change it to an injection that, which overall might take, from start to finish with all the prep and everything, maybe a half an hour to an hour. But we get so much more time with them because we literally can't leave. I love that you brought that up, and what an interesting perspective to keep for nurses as they contemplate and sort of work through this change in practice about some of these unexpected but delightful outcomes that have occurred because of this.
The quality, not the quantity, right?
Absolutely. What additional training or education do oncology nurses need to stay current in this topic?
Oncology nurses who are new to a workplace, whether they're experienced in oncology or not, should receive education and hands-on training through their new hire orientation on sub-Q injections, just like they would with IV chemotherapy administrations. I would urge institutions to create practice guidelines for nurses to be able to quickly reference every day. Annual competencies through online education and hands-on review could also be beneficial to remain current on the topics.
And what are some additional resources for maybe our patients or other providers on our team who want to learn more?
Talked a lot about the package labeling, and resources from the manufacturer is a good start to learn more about specific drug indications, instructions, and they often include patient instructions in there as well. The Oncology Nursing Society also has excellent drug reference sheets that serve as an at-your-fingertip resource that tell you what you need to know from a nursing lens. The one-pager includes important education points for a patient as well. You should also reach out to your workplace for any specific resources they may have. Also should note ONS has voice articles, CJON articles, ONS posters, and now this podcast for reference as well.
Crystal, thank you so much again for coming and sharing your knowledge and your experiences with us today. I think this is a topic that many nurses are interested to learn more about and become more comfortable with, as we've noted on the podcast, such a great benefit to our patients. And so excited to be able to provide this to them and hopefully maybe improve their experience as they go through their cancer treatments. Do you have any final comments to share with our listeners today?
I'm just really looking forward to the future landscape of oncology practice and drug approvals and drug administrations. It's so important that sub-Q injections have really made a name for themselves in nursing practice today. We continue to see more sub-Q formulations on the market that are available for patients, allowing them less time in infusion chairs and more flexibility and freedom outside of the healthcare setting.
Well, thank you again, Crystal.
Thank you so much for having me today.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.